All right? Without further ado, in 2013, the American Heart Association issued new cholesterol guidelines that placed a lesser emphasis on LDL and non-HDL targets and instead introduced the concept of statin benefit groups as well as moderate and high-intensive statin therapy. To discuss this topic, I can think of no one better qualified than our first speaker today, Dr. Karol Watson. Dr. Watson is a professor of medicine at UCLA in the Division of Cardiology. She's the director of the UCLA Preventive Cardiology program, and in addition, she's the director of the Barbra Streisand Heart Health Center. Dr. Watson.
Thank you so much. It's my pleasure to be here today to discuss these guidelines. These are my disclosures. So as Dr. Kwan said, at the end of 2013, we released the ACC-AHA guideline on the treatment of blood cholesterol to reduce atherosclerotic cardiovascular risk in adults. I was a member of this guideline writing committee, which was chaired by Dr. Neil Stone. So I'd like to give you our impression of where it stands now a year and a half later, and what we were thinking when we put what we put in the guidelines. I can tell you, the guidelines started out with a little bit of a tortured history. It was initially convened by the NIH, the National Heart, Lung, and Blood Institute, and it was convened to be the update of the ATP3 guidelines, so we were the ATP4 panel. We worked under these auspices for about 3.5 years. When they convened the panel, they told us what they wanted. They wanted us to scour the literature using randomized controlled trial data and meta-analyses primarily or only, and tell us what works to reduce atherosclerotic cardiovascular disease events, heart events, so that's MI, stroke, and cardiovascular death. It's a very clear charge, but a really small box and pretty different than ATP3, which used much less stringent definition of what kind of evidence they would use. They also didn't require the hard cardiovascular outcomes. So this was a different set of guidelines. We worked under the auspices of the NIH for about 3.5 years, and then at the 11th hour, they sort of said, we want to get out of the guideline writing business, so we're going to hand it over to the professional organization. So they handed our guidelines committee in toto, and our guidelines, which were pretty much finished at that point, to the ACC and AHA. We worked under the auspices of the ACC and AHA for about 6 months. They really did not change the guidelines. They did a lot of review and added more ad hoc reviewers, but they really didn't change the guidelines. And so that's what was published in 2013. Okay, I want to give you our background thinking about these guidelines and some of the inside points that we wanted to emphasize. And I'm going to do it by going through really what we were thinking front and foremost about when we put these guidelines together. The first thing, you'll note that the guidelines seem like a drug guideline, and they really were under the feeling of this. Everyone who has any cardiac risk should be treated with lifestyle. Lifestyle is the basis of all of our treatment. So when the NIH put all the panels together, they put together 3 panels and 3 working groups. The panels were the cholesterol panel, the blood pressure panel, and the obesity panel. The working groups were the risk assessment working group, the lifestyle working group, and an implementation working group, which never got off the ground. But anyway, what they wanted to do was have lifestyle recommendations that spanned all 3 panels. So what we did was we endorsed these in our guidelines, and we said that in the text very prominently. And everything that's in the ACC-AHA lifestyle recommendations is pretty much everything we know we should do. So it's a healthy diet, regular physical activity, things like that. So then we did this exhaustive literature search, really looked at everything we could find. That was a randomized controlled trial or meta-analysis for really the last 40 years. When you do that, it really becomes evident that the best way to reduce MI, stroke, and cardiovascular death is with statins. So with that, we came up with what we called the statin benefit groups. So when we did that, it was important to note that not everybody benefits from a statin, so we didn't want to recommend everyone get one. What we wanted to do was target statin therapy to those groups most likely to benefit and target people away from treating those who are not. For instance, heart failure patients. Really sounds good, makes a lot of sense that statins should benefit them, but when you look at the randomized controlled trial data, it doesn't support that. So we did not make a recommendation for or against treating heart failure patients. The same thing for chronic renal failure, for end-stage renal disease patients. We said the clinical trial data does not support or refute using, so we didn't make a recommendation for or against. But these were the groups that there was clear randomized controlled trial data that they benefited. And again, this is why we focused on statins. When you look at all of the randomized controlled trials and meta-analyses, statins really rise to the top. This is data from the cholesterol treatment and trialist meta-analysis looking at statin therapy for the reduction of cardiovascular events. And there's a real consistency of all the results, really, regardless of where your baseline risk is, regardless of what your risk is driven by, whether it's smoking, blood pressure, or something else. There's about a 25% hard cardiovascular risk reduction for every 40 milligram per deciliter LDL lowering you get with statins. It's important to note also that really all of these trials were fixed dose trials. So for years we had sort of worked under the theory that we needed to get to a certain target and treat to that target and that would improve outcomes. But when you actually look at the trials, you realize that's not how they were done. They picked a drug and they picked a dose and they just treated. And that's really what we saw. So I, for one, was like most of the panel. When we came, we thought, I bet we're going to lower the goals to lower and lower. But when you look at how the trials are done, they're just not done that way. They pick a drug, they pick a dose, and they just treat. Okay, so we came up with these 4 statin benefit groups, and that's figure number 1 from our guidelines, listing the 4 statin benefit groups. The top 3 groups are sort of the very high-risk patients that there really was very little controversy or discussion about. The bottom square is the primary prevention group, which I'll spend a lot of time talking about because that's where all the controversy was. Okay, statin benefit group 1, individuals who have clinical cardiovascular disease, acute coronary syndrome, myocardial infarction, angina, already revascularized. Everybody agreed they deserve treatment. So what we said is if they're under the age of 75, we recommend high-intensity statin. If they're above the age of 75, we recommended moderate-intensity statin therapy. And that was actually only because there's pretty good evidence that most statin side effects are increased in individuals over the age of 75. Statin side effects are dose-related. So we said in this higher risk group, but higher risk for adverse events also, we recommend a moderate dose. The next statin benefit group, also very little controversy. These were individuals with LDL cholesterol above 190. Those are individuals who we recommended high-intensity statin therapy because that's what you're going to need to get their LDL down to a level which we believe they're no longer at risk. The reason we put this in there, if you do their risk calculator with these individuals, they will calculate low because most of them are young, because they don't live when they're really old. But most of these individuals will not calculate to be a high risk, but most of them will have a genetic dyslipidemia. It's almost impossible just to eat yourself up to an LDL of 190 without having some genetic defect. We recommend family screening in these patients as well. Statin benefit group number 3, people with diabetes, both type 1 and type 2. Now this group, the type 2 evidence was clear. For type 1 diabetes, we actually made it an expert opinion because there's much less evidence in that group. We say in the document ages 40 to 75 only because that's where the clinical trial data was, but we also say it's really reasonable to treat someone under the age of 40 or over the age of 75 if they have diabetes because it's likely they're going to achieve the same benefits. Very little discussion or controversy about this recommendation either. Now, statin benefit group 4. These are individuals who are primary prevention. They'd have no clinical cardiovascular disease. They don't have really high LDL. They don't have diabetes. But they have an estimated atherosclerotic cardiovascular disease risk of greater than or equal to 7.5% over the next 10 years. And for them, we recommend moderate to high-intensity statin therapy. This is the most controversial part of the guidelines. We also said 7.5 is the threshold which we really want you to recommend it, but it's reasonable, we said, to recommend it down to a risk of 5% over the next 10 years, and I'll show you how we came up with those numbers. As I said, most controversial part of the guidelines. Because of the risk calculator, to a large part, and also because of the lower thresholds of treatment, but I'll explain to you why we got there, where we got to. Let's talk about statins for primary prevention. Well, we were fortunate to have two very well-done meta-analyses to base our recommendations on about the same time the guidelines were being completed. The most recent one was the Cochrane meta-analysis, which was done by Fiona Taylor. In this meta-analysis, she looked at all the primary prevention statin studies that she could find, and then looked at all the important outcomes, all-cause mortality, cardiovascular mortality, coronary heart disease, stroke, non-cardiovascular, et cetera. And what they found was that if you look at the statin treatment, those individuals had a significantly lower risk of all the major outcomes. The only one that didn't go the right way was type 2 diabetes, where there was an increased risk, which actually just met the limit of statistical significance. We'll talk about that. The cholesterol treatment trialists had performed a primary prevention meta-analysis about a year before, and so we had access to that as well. And what they found was that if you look at the x-axis going across, that's the LDL cholesterol reduction. So the more LDL reduction is over to the right. If you look at the y-axis, that's the number of vascular events avoided, vascular deaths avoided. And if you look across the z-axis, there's the baseline risk of the patient. So if you start off as a low-risk patient and you give a statin, the more statin you give, the more vascular events are avoided. But as you increase the risk of the primary prevention patient, the more statin you give, more LDL reduction, the more events are avoided. So this was pretty clear evidence to us that the higher risk primary prevention patients should be treated with a statin. Okay, but there was a lot of controversy. A lot of people had a lot of things to say. I'm going to talk a bit about the risk estimator and also about how we got our treatment threshold, where we decided we should recommend treatment. Okay, here's the ASCVD risk estimator. It is available for Apple products and for Android products. It's a free download, and I highly recommend that you all do that. These are the variables that are put into it: gender, age, race, total cholesterol, HDL cholesterol, systolic blood pressure, whether or not you're on treatment for high blood pressure, diabetes, and smoking. You put all those variables into the equation, and it spits out both a 10-year atherosclerotic cardiovascular disease risk and a lifetime risk. We thought the lifetime risk was really important because for young individuals, you're probably not going to get a high enough 10-year risk, regardless of what the risk factors are. But we know that if they have a very adverse risk factor profile, their lifetime risk is very high. What's different about this is a couple of things. One is race is included, and by that, they only have two fields for race. It's either white or African American. But if you open up the decision support tools that are available on this download, they talk about other ethnic groups as well. They talk about Asians, South Asians, Hispanics, and tell you how you should think about those patients. The other thing that's different is diabetes is included. If you'll remember the old Framingham risk estimator, diabetes was taken out because diabetes was a risk equivalent. We now have a lot more information about diabetes, that it's a very heterogeneous disorder. Some patients are very, very high risk, and it's reasonable to treat them like they have coronary heart disease, but some are not. And those patients, it doesn't necessarily make sense to. Now, again, all of these patients are recommended for statin therapy, But if they are a patient with diabetes who you do the atherosclerotic cardiovascular disease risk estimator on, and they turn out to have a risk lower than 7.5%, we recommend moderate intensity statin therapy. If they have a risk estimator that comes out to be above 7.5%, we recommend high-intensity statin therapy. The other difference about this risk estimator as compared to Framingham really only predicted cardiac events. This risk estimator predicts stroke and coronary heart disease events, so we thought was very important. Here's how we got the thresholds. Whenever you treat someone with a therapy, you want to base the decision to treat on the risk-benefit ratio. If the risks exceed the harms, if the benefits exceed the risks, we recommend that therapy typically. So what we wanted to do was to put together all the risks, the harms that we could think of, and calculate a number needed to harm. And when we did that, we threw every harm in there that was that came out in any statin trial, even if we didn't think it was causal. So we put in hemorrhagic stroke, diabetes, myopathy, LFT abnormalities, everything. And when you calculate a number needed to harm, it's constant, regardless of the baseline cardiac risk of a patient. So when you look at the cardiac risk of a patient down here, it doesn't change going across, and the number needed to harm and for high-intensity statin therapy are shown there in red, and for low to moderate intensity statin therapy are shown there on the right. Now, the number needed to treat for benefit does vary according to the baseline risk of a patient. So the higher the baseline risk of the patient, the lower the number needed to treat. So you end up getting this curvilinear relationship. So what we decided was that if the number needed to treat for benefit was below the number needed to harm, that was a reasonable therapy to recommend and at that threshold. And if you look at the 7.5% threshold, it's well below the number needed to harm for high-intensity statin therapy. And even the 5% threshold that we say is an optional treatment level is well below. If you're talking about low to moderate intensity statin therapy, you actually never exceed the number needed to harm. So we actually don't recommend low-intensity statin therapy for anybody in our guidelines, but that's what the data looks like. Okay. Now let's talk about the risk estimator. As I said, we worked in parallel with the risk assessment working group, and we actually, there was some talking back and forth, but they worked all alone and came up with this, and that risk estimator was adopted by all the panels. How do you make a risk assessment clinical prediction tool? Well, you have to figure out what population you want to derive it in, and it makes sense to derive the risk estimator using data that looks just like the population you actually are going to apply it to. That's the first thing. So Framingham only used Framingham, but in this risk prediction calculator, we used Framingham original cohort, the Cardia study, which is a younger multi-ethnic cohort, the cardiovascular health study, which is an older cardiovascular risk cohort, and the ERIC study, which is a middle-aged atherosclerotic multi-ethnic group. After you do that, you then do validation. So you come up with your risk prediction tool, and then you want to validate it. To validate it, you want to validate it in the same populations in which you will apply it ultimately in. So for that, we use the multi-ethnic study of atherosclerosis, which is a multi-ethnic cohort. The REGARDS study, again, a more African-American cohort. The ERIC study, multi-ethnic, and the Framingham current cohort study. That's what we did. Now, the final step is where you do impact analysis. You say, okay, this is what we did. Does it really work? And that's where we are right now. One of our external reviewers for the cholesterol guidelines was Paul Ridker. Paul Ridker is a great cardiologist at Harvard, and so he had all the data, and he had sort of his guns ready. So the day the guidelines were released, he also released his report. He basically said, come on, you guys, this risk estimator overpredicts. He didn't mention that to us when he actually reviewed our guidelines, but this is what he did the day after the guidelines were released. So he said, I'm going to use my own cohort, the nurses' health study, also called the women's health study, and the physician's health study. to see if this risk estimator predicts well. And lo and behold, it didn't. So if you look at the predicted number of events, which are shown in red, they're higher at every risk level than the observed number of events shown in blue. This is data for the Women's Health Study, and this is data for the Women's Health Study here, Physicians' Health Study here. So the predicted events are shown in red, the actual events shown in blue, and you can see at every level they were higher. So he said, this thing doesn't work at all. But when you think about it, as I mentioned, you're supposed to use this risk estimator for a general, multi-ethnic, multi-risk, average income, average everything American population. When you look at these two cohorts, U.S. physicians, U.S. women healthcare workers, they're much higher sociodemographics than the average U.S. population, much healthier than average, and many of them were actually taking statins. The risk estimator is not meant to be used in a population already taking statins. It's meant to be used to decide on statin therapy. Okay, so let's look at other cohorts. Rotterdam, it's a observational study in the Netherlands. And what they found was, if you look at the Rotterdam cohort, it also showed poor calibration. It didn't predict very well. So the number of predicted events was higher in this Rotterdam study as well compared to the actual number of observed events. So you think, oh, what's going on here? But then you think, who cares what's going on in Rotterdam? These are meant to be American guidelines, and they're meant for a broad-based U.S. population, okay? So they did another study, Epic Norfolk, observational study out of London, an area outside of London. And in this study, they actually showed excellent calibration. The number of observed events was actually about the same as the number of predicted events. But I reiterate, who cares how it predicts in Norfolk? What we want is it to predict well in U.S. cohorts. And when you look at them, it does predict pretty well. The REGARD study, as I mentioned, is a population-based study of black and white patients who are being followed for atherosclerotic cardiovascular disease, predominantly stroke. And in a validation study, they found that the risk estimator performed very well. Again, if you look at the predicted events here, shown as the blue bars, and the observed events shown as the red bars, they're virtually identical. So in this population, it performed very well. The investigators from the Dallas Heart Study also just recently released a report saying that the risk estimator performed very well in their cohort as well. So they say, our results from a contemporary, multi-ethnic, younger population suggest that the application of the ACC-AHA guidelines will have a favorable effect on ASCVD prediction with reasonable efficiency of statin use when compared with the prior ATP3 recommendations. So what we're starting to see is that when the risk estimator is applied to populations for which it was intended, it actually performs pretty well. Okay, let's go back to the guidelines. One of the other things we put in there, which was actually new, if you look at a lot of treatment guideline recommendations, you won't see this. This was new, and we thought we were going to get a lot of controversy about this, but we got almost none. We recommend that when you're using statin therapy for primary prevention patients especially, you need to really engage in a patient clinician discussion about this. This is a therapy that's meant to reduce risk, and that's something that's sort of hard to get your head around, and you have to get buy-in from the patient. If they're not willing to do this, then there's no reason to even attempt because it's not going to work. So we really did emphasize patient-shared decision-making. This is what we envision sort of a clinician-patient decision-making discussion might look like. First of all, review their risk factors and their risk factor control. Because they're primary prevention, you're going to estimate their 10-year ASCVD risk. Now, in some patients, either their estimated risk just doesn't jive with what you really think their risk is, or you think there's a hidden risk somewhere. There are a number of things that we put in the guidelines that you can use sort of to help upgrade your risk. So if they have LDL above 160, family history of premature atherosclerotic cardiovascular disease, HSCRP above 2, coronary calcium score above 300, or an ACL brachial index less than 0.9. There are other things, but these are the ones that we put in the guidelines because they have the best evidence behind them. So after you do that, we say we really want you to discuss lifestyle with the patient. So review the potential benefit from lifestyle. Then it's really important to think about potential benefits from statin, potential harms from statin, and certainly drug-drug interactions. And then finally, and probably most importantly, you need to take into account the patient preferences. Okay. Then the other thing that was pretty controversial in the guidelines was that we said, after we looked at all the data, we said the current evidence is inadequate to support treatment to specific LDL cholesterol and or non-HDL cholesterol goals. So that meant no more LDL goals. And what we instead wanted people to do was to use the intensity of statin therapy that was studied in clinical trials. So this is a figure exactly from our guidelines as well, where we talk about high-intensity statin therapy, moderate intensity, and low intensity. Now, we defined high-intensity statin therapy arbitrarily, and I will admit it was very arbitrarily, as anything that gives you an LDL reduction of about 50% on average. When you look at which drugs can do that, there's only two, either atorvastatin or rosuvastatin, only at 2 doses for each of them. Atorvastatin 40 or 80, rosuvastatin 20 or 40. When we talked about moderate intensity statin therapy, we arbitrarily defined that as anything that gave you a 30 to 50% LDL reduction. And these are the drugs and doses that can do that. And again, we don't actually recommend low intensity statin therapy for any patient, but those are the drugs that do that. The drugs and the doses that have been studied in clinical trials are highlighted in yellow in this chart here. You can see not all of the drugs and all of the doses have been studied in large-scale clinical trials, but we believe the consistency of data with statins is such that we think the benefits will be the same in all of the cases. Okay, so here is how the guidelines look. You have an adult over 20 years of age who's a candidate for statin therapy. You ask the first question, do they have clinical atherosclerotic cardiovascular disease and are less than 75? If the answer is yes, then you give them high-intensity statin therapy. If they're over 75, give them moderate. If the answer is no, you ask the next question. Is their LDL above 190? If the answer is yes, they get high-intensity statin therapy. If the answer is no, you ask the third question. Do they have diabetes, either type 1 or type 2? If the answer is yes, they get high intensity if their estimated risk comes out to be above 7.5. They get moderate intensity if it's below. I'm sorry, that's a typo there. But if the answer is no, then you ask the fourth question. Do they have a 7.5% or greater 10% estimated cardiovascular risk? And to do that, you have to use the risk estimator. If the answer is yes, then you give them moderate or high-intensity statin therapy. If the answer is no, what we wrote in the guidelines is you just continually reassess. We wrote every 4 to 6 years. I see my patients more often than that, but just continue to reassess and recalculate their risk. The other thing we put in the guidelines was follow-up. So what we recommend is that you do repeat lipids, and there's some misunderstanding out there about that. You definitely do repeat your lipids. You actually assess them initially at 3 to 12 weeks following initiation of therapy, and then periodically thereafter. I do every 6 to 12 months, depending on my patient's risk. If they have the expected response, and by expected, what we said that we don't have data to either argue for or against LDL goals, but we understood that many clinicians would have in their minds an LDL that they felt their patient should be below. So if you have the expected response, then great. You pat them on the back, you congratulate them on their adherence, and you continue routinely following them. If the answer is no, then you have to ask why. Is it statin intolerance? If the answer is yes, then you have to figure out how to manage that. So we actually put into the guidelines a number of tips for managing statin intolerance, and that includes things like switching statins, changing to a lower dose, alternate day dosing, even as little as once a week dosing. But what's important is we say max intensity tolerated statin therapy for patients who you recommend high intensity. If they can't tolerate that, we don't say just abandon the statin, get them on some dose of a statin as long as it's tolerable. If they don't have statin intolerance, ask them if they're being adherent and reinforce medication adherence, and then hopefully get them to get the expected response. And if that happens, then you go ahead and reinforce compliance and adherence. If not, then you have to figure out what else you want to do. Again, if you believe your patient should be at an LDL level that's lower than what they currently are, you can either increase the dose, reinforce adherence, or considering adding a non-statin drug to your statin. Okay, what do we say about adding a non-statin drug? Well, we say, again, use the maximal and tolerated intensity of statin therapy. So don't ditch the statin and switch to a non-statin. We'd like you to get the patient on a statin for the optimal risk reduction. But then you can consider addition of non-statin cholesterol-lowering drug if there's a less than anticipated therapeutic response, but really only if you really believe that the benefit will outweigh the risk. And for the higher risk patients, that's the ones that it's most likely to be true for. We then recommend that non-statin cholesterol-lowering drugs shown to reduce atherosclerotic cardiovascular disease events in randomized controlled trials are preferred. Now, recently, we had a new trial called the IMPROVE-IT trial, and it was very important because it was the very first trial that had ever shown incremental cardiovascular risk reduction when you add a non-statin to a statin. So this trial was ended up being over 20,000 patients who had a recent acute coronary syndrome. They were randomized either to ezetimibe plus simvastatin 40 or simvastatin alone. Then they looked for the primary endpoint of cardiovascular death, MI, unstable angina, revascularization, stroke, or bleeding. And they found there was a benefit. So with the group that got the simvastatin plus the ezetimibe, they had a reduction in clinical events. So again, the very first trial that showed additional benefit of adding a non-statin drug to a statin. And when you look at the meta-regression line of cholesterol reduction, which shows where a trial ends up on this line, the amount of LDL reduction they get going across and the cardiovascular event reduction they actually achieve, it falls right on that line for major cardiovascular events and hard cardiovascular events. So we were actually quite pleased to see this trial. It's only been presented at the American Heart Association last year. As soon as it's published, we're going to incorporate it into the guidelines. How will we incorporate it? Well, it won't have the same class of recommendation as statins. There's so many different statin trials that have gone into making that a class 1 recommendation level of evidence A. At most, it will be a 2A or 2B level of evidence B, but we will incorporate it into the guidelines once it's published if the results are the same as what we've been presented. Okay, some common misconceptions about the guidelines. Some people think that all patients with a 10-year cardiovascular disease risk of greater than 7.5% need to be treated. It's not true. We actually really do emphasize that patient-provider discussion, and we want the patient preference to take really supreme importance in that discussion. Some people think there's no longer a role for rechecking lipids, and I hope I've convinced you that we do say that you should recheck lipids about 3 to 12 weeks after initiation of your statin, and then periodically every 4 to 12 months. Some people think there's no role for non-statin therapy, and I think I've just shown you that there really does remain a role depending on what the clinician believes the LDL level should be. And finally, other people believe that the new risk estimator abandons Framingham. It doesn't at all. It includes Framingham along with 3 other well-validated cohorts to try to add power and diversity. Okay, finally, the last thing I want to try to, I hope I've convinced you of the efficacy of statins. I want to talk to you about the safety. Statins are remarkably safe drugs, but just like any drugs, they have side effects. Some side effects that have been touted and that patients worry about really are probably nothing to worry about. Others really are something to worry about. So I want to go through each of these: liver, muscle side effects, cognitive effects, cancer, and diabetes. What about the liver? Well, for years, what we've done is checked LFTs before initiation, every 6 months, anytime you change the dose. I mean, we were really vigilant about checking LFTs because we worried that statins might be hepatotoxic. What the FDA 2 years ago, though, came out saying is that, we don't see hepatotoxicity like we thought we were going to. So you need to check your LFTs before you initiate them, but you don't have to routinely check. That was a really, really rare move by the FDA. Without encouragement or any kind of lobbying from any drug company, they actually took away a prescription that they had done for years. What they said was in early clinical trials, LFT elevations were seen, so healthcare providers were advised to regularly follow LFTs. However, the FDA found that statin liver damage is rare, and LFTs are not effective at predicting or preventing this rare side effect, so FDA is now recommending that LFTs be performed before statin treatment begins and then as needed if there are symptoms of liver damage. So that's the liver. Let's talk about the muscle. Now, the muscle side effects are showing the one side effect I really do worry about, and that's because we do sometimes see deaths from that. Statin adverse effects are of various types. There's what I call the achy, painy feeling, which is just myalgias, and that's actually pretty common. I run a lipid clinic, and I see a lot of patients like that. It's common, but it's not dangerous. It's never been shown to lead to muscle damage or any adverse event. Myopathy, however, is when you have the achy, painy feeling plus an elevation in your CPK. That means you are actually getting some muscle damage. Again, it's pretty rare, about 6 cases per 100,000 patients above placebo. But it's concerning to the patient, and the increased CPK makes us worry about muscle damage. So if the CPK is more than 10 times the upper limit of normal, that is the definition of myopathy. Now, no deaths occur because of myalgias or myopathy. What can cause deaths are true rhabdomyolysis. That's a frank idiopathic muscle breakdown. It's not just statins that can cause it. A lot of drugs and a lot of other things can cause it. But when it happens, it can be life-threatening, and that is what I worry about. So the incidence is low, only about 1.6 patients per 100,000. But when it happens, it can be life-threatening. So every patient, every last one, whenever they get their statin, they get this warning. Any unexplained tenderness, muscle pain, weakness, stop the drug and call me. Every single patient gets it. If you get a patient with rhabdo, stop the drug, give them hydration, they'll be fine. But you don't want to let that patient continue to take their statin or go on otherwise unmonitored. Okay. How can we know that statin muscle effects happen? In randomized controlled trials, it's a really low reported rate, but when you think about how the trials are done, almost all of them have an active run-in phase. That means they have, before they even randomize them to either the statin or the placebo group, they give everybody a statin and see who can tolerate it. If they can't tolerate it, they get kicked out of the system. They never even get randomized. So the incidence rates are very low in randomized controlled trials, but in real life, it's probably much higher. It's probably much closer to 10%. Myopathy and rhabdomyolysis are associated with statin therapy as a class effect. Every single statin can do this. The risk increases with increased statin dose and with drug-drug interactions. But prior to initiating statins, patients need to know to promptly report any unexplained muscle pain and/or weakness. Everybody gets that warning. There are some patient characteristics that increase the risk of statin myopathy and some statin characteristics that are shown here. The ones I want you to focus on in the randomized controlled clinical trials, if you look at who gets rhabdomyolysis, is overwhelmingly the little old ladies. So thin, low muscle mass, get massive dose of statin. They're the ones that are most at risk. Okay, cognitive effects. If you look at observational studies, it looks like the patients that get a statin actually look like they have a lower incidence of cognitive impairment. And there's another analysis done, sort of a post-hoc analysis of about 60,000 individuals over the age of 65, no history of dementia, who were taking statins. They divided them up into tertiles according to the statin dose they were taking, and then looked at who got cognitive impairment. Turns out that those individuals who were taking the highest dose of the statin had the lowest incidence of cognitive impairment. There's sort of a stepwise increase as you go from moderate to low. So these look pretty good, right? Well, there's a reason we do randomized controlled trials, because a lot of confounders can be seen both in the observational studies and in this type of analysis. When you look at randomized controlled trials where they look specifically for cognitive disorders, you actually don't see anything. No harm, but no benefit either. This is from the heart protection study, 20,000 individuals given simvastatin or placebo. No real change. A more important study was the Prosper study, because this was a study that was done all in elderly patients. So all of these 5,000, almost 6,000 patients were over the age of 70. They got 40 milligrams of premastatin or placebo, and they actually did formal neurocognitive testing. No benefit, no harm at all. Okay, so what the FDA said in 2012 of their advisory, they said, there have been rare post-marketing reports of cognitive impairment, in other words, memory loss, forgetfulness, amnesia, memory impairment, confusion associated with statin use. The times I hear of it, it's called like this foggy brain feeling patients talk about. These reported symptoms are generally not serious and reversible upon statin discontinuation with variable time to symptom onset, 1 day to years, and symptom resolution, median of 3 weeks. So that was another weird step by the FDA. They looked at all their database and found no cognitive impairment signal at all. But they said, we're getting all these reports. We need to pass it along. We don't know what it means, but this is what we see. Cancer, nothing. No harm, no benefit, whether you slice it by statin dose, years of use, baseline risk factors, there's just nothing there. No increased risk of cancer, but it doesn't appear that there's any significant reduction either. And the final thing is diabetes. There is a diabetes signal. So if it took us, we were using statins at pretty good frequency for about 20 years before we saw the first signal of diabetes. That occurred in the Jupiter trial. That was a trial of primary prevention patients, most of which who had the metabolic syndrome. They had high-intensity rosuvastatin or placebo. They had a significant cardiovascular risk reduction, but out of that trial, they saw for the first time there was a statistically significant increase in diabetes development in the statin users. Turns out, then we went back and looked at a bunch of different statins, and it looks like most statins can cause it as well, so it's probably a class effect. When you look at that same Jupiter trial, which is the first trial that showed us the signal in the first place, a really interesting thing comes out. If you split, so like I said, many of those patients, actually most of them had the metabolic syndrome, but those that didn't and didn't have any major risk factors for diabetes, they had a significant risk reduction with the rosuvastatin, and they had no excess cases of diabetes. So these patients had the benefits but didn't have this risk from the rosuvastatin. If you did have major risk factors for diabetes, metabolic syndrome, obesity, et cetera, those are the patients who still had a significant benefit, 134 deaths or vascular events prevented, but all of the excess cases of diabetes happened in that group. So what it looks like is statins tend to raise blood sugar levels about 2 to 3 milligrams per deciliter. In most of us, that's not going to make a difference, but if you're teetering right on the edge of developing diabetes, it might tip you over. The investigators estimated that it accelerated the diagnosis of diabetes. They said about 3 weeks. I thought it was probably closer to a year, but we both made up those numbers, so I don't know. I'm being honest. What the FDA said was there's a small increased risk of elevated blood sugar levels and the development of type 2 diabetes have been reported with the use of statins. Clearly, we think the heart benefits of statins outweigh this small increased risk, but blood sugar levels may need to be assessed after instituting statin therapy. Okay, so statins. most efficacious LDL-lowering agents, and they have the greatest cardiovascular risk reduction. Liver damage, very rare, and probably there's actually never been a case of documented liver failure with statins. Statins can produce muscle pain and weakness, but the risk of true rhabdomyolysis is small, but you still have to give them that warning. Unexplained muscle tenderness, pain, weakness, stop the drug, and call me. Statins in clinical trials have found no evidence of cancer or cognitive impairment. Statins can increase blood glucose levels minimally, leading to increased reports of diabetes, but in patients at high cardiovascular risk, the benefits of statins far outweigh the risks. Thank you very much for your attention.
We have time for a few questions. If you have a question, raise your hand. We'll get you a microphone, and you can pose your question to Dr. Watson.
Yes.
First question is, what is your expected response? Are you looking at LDL for the risk?
The question is, when I say if they obtain the expected response, by that we meant LDL reduction. And again, we don't put LDL levels in our guidelines, but we assume that many clinicians will have an LDL level that they really do believe their patient should be low. Yeah, no, and I kind of wish we hadn't put that into the guidelines, because we don't recommend you look at the percent LDL reduction, because again, that's not how the clinical trials were done. And I admit we arbitrarily defined high-intensity statin therapy as a 50%, but it's not that we want you to aim for 50%. It's just that these are the drugs at the doses that in clinical trials caused about a 50% reduction.
And number two, the most common interaction I'm going to do is gal patients that need to come on colchicine for 1 day. Do I have to stop the statin? What do you do for acute therapy?
Yeah, so that's not one of the interactions that you have to stop. Most of them are the really, really potent CYP3A4 inhibitors, like drugs like antibiotics and some protease inhibitors, where you do really have to be careful.
It looks like it was included in the risk estimator, the HDL cholesterol, but I always look at that if my patient has a high HDL, that's very protective. We didn't comment on that.
So we used to think that HDL was this great anti-atherogenic molecule, but there's many, many reports now that not all HDL protects. And in fact, if you look, that's our big research interest at UCLA, and many studies have reported high HDL levels actually causing increased risk rather than being protective. So the way it's still put into the risk score, because I mean it does come out in epidemiologic, but we don't ever ignore a really high LDL just because the HDL is good. Yes.
Yeah, two questions. One, any role for VAP studies, lipid subfractions, myeloperoxidase, in risk calculation and making decisions about management? And number two, when you do have a statin-induced myalgia, do you ever try just reducing the dose or switching to a different statin?
So I'll answer the second question first. I always, I have my favorite statins, and I always just try going down in dose, and it typically works. That's question number two. Question number one, most patients don't need a VAP, but there are some instances where I'm sure there's hidden risk in a patient, and I do use some of that data. I'll give you an example. I had a youngish woman who has a really bad family history, and her LDL looked pretty good. And I'm like, okay, something's going on. I got a VAP. Her particle number was like 4,000. It was ridiculous. So in her, I actually put her in a statin despite the fact that her LDL looked pretty good. But most patients, the risk is pretty obvious. It's only in those patients I'm worried about a hidden risk. You had a question?
Person in the back.
Oh. So this is so interesting. I'm going to give you all my secrets, you guys. Still send them to me, though. So the question was, what is the minimum dose of a statin at which you can usually get a benefit? And I can tell you I do this a lot, and I have gotten benefit in terms of LDL reduction, but there are no outcome studies at this dose. But if you give rosuvastatin, the lowest dose pill they make is 5 milligrams. Tell them to cut it into quarters. Give as little as 1 a week, and you get some significant benefit. I just yesterday called the patient back with his LDL results on that. He went from 140 to about 83.
Two more. One in the back. Oh, wait, sir. In the back.
No, it was once a week. I'm sorry.
How do you use the risk calculator if they've already been on a statin?
You can't. So you can't use, the risk calculator is absolutely not meant for someone who's already on statins, so it's not intended to be used.
One last question here.
Yes.
Your risk calculator does not take into account family history. I
does
have
not.
so many patients that they look great, okay, but yet they have a horrible family history of premature atherosclerosis and cardiac events. So some of them have chosen to do the CAT scan at Harbor. And so then how do you decide whether or not to treat? Because looking at your calculator, you think, well, gosh, these young guys that are 50, 52 with LDLs of 170 with great lifestyle, perfect everything, shouldn't be treated. What do you want?
So
what's your recommendation?
That's a great question. And remember I showed you in that patient-provided risk assessment discussion, the things that you can look at in addition to what their estimated risk is, if you want to classify someone, is coronary calcium above 300. But I look at strong family history as well. There's no question. And the reason it's not in the risk estimators is because every time you look epidemiologically and then adjust for things like blood pressure, HDL, et cetera, family history drops out.
So then with somebody who has an LDL of 170 with a family history of father dying of a heart attack at age 49, 47, what's your target then? Does the LDL really not matter then?
No, the LDL does matter, but my target then is to get them on statin. I'd put them on a moderate dose statin. I don't use a percent drop or an LDL goal. I just use the intensity of statin therapy.
Because then at 170, premature heart disease, all bets are off. Do you aim for a 50% reduction as in a high-intensity statin treatment? Or
No, you
just
don't
wing
aim
it?
for rejection. You get them only on the intensity of statin therapy. That's what our guidelines. Does that make sense? So you don't have to say, I'm going to aim for 50%, and then if I don't get them there with this statin, I'll then add Zeti or niacin or something. No, just get them on the intensity of statin therapy we recommend.
Okay, wait. I'm a little slow maybe, okay? So if I have a 170 to start, premature family history, I think I want to put them on something. So what do I tell the patient? Is there
Moderate
a
or-
target that I'm going for?
No, there's no more targets. Moderate or high-intensity statin therapy. So let me say a word about target. There's a real problem with targets. A target implies that it just doesn't matter how you get there, and it clearly does. Statins are by far the best way to get there. Target also implies that we know where risk tails off. We have no clue, so we may feel better about a target, but again, we're making it up. A target further implies that if you're just above the target and you give a tiny dose of a statin, then you've reduced risk. But we clearly know that higher intensity statin therapy gives you more risk reduction. And probably the worst possible thing a target can do, it tells you that if your patient's already below targets, you just don't need to treat them with a statin, thereby really depriving them of the benefits of these life-saving drugs. So there's real problems with targets.
So how long would you actually place the patient? Oh, right here. Right here.
I'm sorry?
I'm right here.
Oh, sorry.
How long would you actually put or place the patient on therapy for adult patients that have more than 7.5?
Yeah, for as long as you like them. No, I'm just joking.
So do you
for as long as they're living, because you're going to take away the benefit if you take away the statin.
So do you have to recalculate the risk factor like
No,
yearly, or
no,
you don't? You just
no.
put them on indefinitely, or?
Exactly, forever, yeah.
Most common side effect I hear from statin is cognitive impairment. You said there's no evidence of that, and it's amazing. That's the most common side effect that I hear.
So I got to tell you, I've looked at the data too, and there really nothing comes out of the clinical trials, but think about this. The brain is a big bag of cholesterol. There are some people who feel lowering your cholesterol, whether it's by a drug or by LDL apheresis. Some people just feel it, and I don't doubt that, but there's no systematic evidence of it. He's kicking me off.